Now we are learning surgical treatment. 1. Operation position. Generally, spine or semi-sitting position or beach chair position is adopted, and the neck is extended. A small cushion can be placed horizontally under the shoulder blade to help expose the front of the neck and pay attention to avoid excessive extension of the neck. 2. Anesthesia. Trachea intubation is usually used for general anesthesia. Operation gently, carefully stop bleeding, and pay attention to the protection of parathyroid gland and recurrent laryngeal nerve. Post-operative treatment. 1. Body position. Take the flat lying position before the anesthesia is awake, and change to the semi-lying position after the blood pressure is stable and the anesthesia is awake, so as to facilitate breathing and drainage. 2. Condition observation. Pay attention to the vital signs, neck and incision, and find the post-operative complications in time. 3. Diet. Clear mind. No nausea and vomiting. Take a small amount of warm boiled water orally first. Check the swelling condition of the patient and understand whether there is damage to the internal branch of the superior laryngeal nerve. If there is no choking phenomena, you can gradually transition from liquid food to general food. 4. Observation and treatment of post-operative complications. 1. Post-operative dyspnea and asphyxia. It is the most serious post-operative complication. Most of them occurred within 24 to 48 hours after operation. Reason: bleeding or hematoma compression, laryngeal edema caused by surgical trauma or endotracheal intubation, tracheal collapse, bilateral recurrent laryngeal nerve injury, sputum obstruction. Manifestations: the patient has progressive dyspnea, irritability, cyanosis, asphyxia. Treatment: once dyspnea is found, give first aid at the bedside immediately. Remove the cause. If it is bleeding in the incision or hematoma compression, physical examination can find that neck swelling and incision bleeding. Cut the suture immediately. Open the incision and remove the hematoma. In case of respiratory obstruction caused by epileptic edema, glucocorticoid should be injected intravenously immediately to reduce the swelling. If the airway is blocked by sputum, immediately suck sputum and clean the respiratory tract. If the dyspnea is still not relieved after the above treatment, endotracheal intubation or tracheotomy shall be carried out immediately, and further examination and treatment shall be carried out after the life sign is stable. Dyspnea and asphyxia are emergencies that seriously threaten the patient's life. So sterile gloves and tracheotomy kits or endotracheal intubation should be routinely placed beside the patient's bed after thorough surgery for emergency use. Patrol inspection and observation should be strengthened after operation in order to find and deal with it in time. Recurrent laryngeal nerve injury. Reason: when dealing with the inferior thyroid artery and its branches, we should operate carefully to avoid massive ligation. Otherwise, it is easy to damage the recurrent laryngeal nerve. Recurrent laryngeal nerve injury can be divided into permanent damage caused by cutting or swaying, temporary injury caused by intraoperative traction, contusion, clip, hematoma compression or post-operative scar compression, adhesion and traction. One-side injury, many manifested as low voice and hoarseness. The manifestations of recurrent laryngeal nerve injury are bilateral injury, loss of voice or dyspnea, asphyxia. Handle. Patients with unilateral injury can be treated with acupuncture, physiotherapy, and drugs first. Hoarseness caused by temporary factors can usually be recovered after 3 to 6 months. If it cannot be recovered, surgical exploration can be considered. Patients with bilateral injuries can have dyspnea after operation. Tracheotomy should be given first to keep the respiratory tract unobstructed. After the condition is stable, surgical exploration and diving repair should be given. Injury of superior laryngeal nerve. Reason: the superior thyroid enter across the superior laryngeal nerve at the place far away from the gland. If it is too far away from the gland when dealing with the superior thyroid entry, it is easy to damage the superior laryngeal nerve. The internal branch is mainly the sincere branch. When the injury is manifested in the loss of sensation of laryngeal mucosa, choking, and coughing easily due to swallowing, especially when drinking water. Most patients with superior laryngeal nerve injury can covered by themselves after acupuncture, physiotherapy, and drug treatment. Parathyroid injury. Reason: contusion or accidental cutting of parathyroid gland during operation managing parathyroid blood supply, resulting in insufficient secretion of parathyroid hormone and decrease in serum free calcium concentration. The level of serum calcium ion in mild patients can be reduced to less than 2 mol/liter and even to 1 to 1.5 mol/liter in severe patients. Most patients have the following symptoms with 1 to 3 days after thyroidectomy. Mild patients mainly manifested as acupuncture like numbness or rigidity in the face, lips, or hands and feet. Several patients persisted spasm of facial muscles, hands, and feet with pain can occur, which occur many times a day and last for 10 to 20 minutes each time. It can even lead to asphyxia due to severe spasms of throat and diaphragm. After 2 or 3 weeks, compensatory hypoplasia can occur in the undamaged parathyroid gland, and the above symptoms can disappear. Prevention: when removing the lateral lobe of the thyroid, attention should be paid to keeping the back of the gland intact. All the thyroid tissue cut off should be naked routinely. Once the parathyroid gland is found by mistake, it should be implanted into the sternocleidomastoid muscle immediately. The treatment of hand and foot convulsions caused by parathyroid injury is mainly diet adjustment and medication. Diet: pay attention to reducing the intake of foods that affect calcium absorption, mainly meat, dairy products, and eggs with high phosphorus content. Medication: patients with mild symptoms can take calcium gluconate or calcium lactate 2 to 4 gram orally (TID). Those with severe symptoms can take VITD 315 to 1000 day or hydrotestrol oil. It is necessary to regularly detect the blood calcium concentration during medication to adjust the supplement amount of calcium. If the patient has severe hypocalcemia and convulsions, the following first aid measures should be paid attention to. Provide dental pens to prevent tongue bite. Slow intravenous injection of 10% calcium gluconate 10 to 20 millimeters. If permanent hypothyroidism occurs, allogenic thyroid transplantation can be considered. Thyroid crisis, common in 36 hours after operation. The main reason is the poor control of preoperative hypothyroidism symptoms and the inadequate preparation of iodine. After such circumstance, thyroid surgery is easy to squeeze a large amount of thyroid hormone into the blood circulation and enhance the role of catecholamines. However, the blood lacks the ability to adapt to this sudden change, resulting in increases. The typical manifestations are sudden high fever, rapid pulse increase of more than 116 times minute, sweating fair, vomiting, delirium common, etc. There are also a few patients with apathy, weakness, decreased tendon reflex, hypothermia, slow pulse rate, and low pulse pressure. This kind of hypothyroidism crisis is apathy. First aid measures for hypothyroidism crisis include general treatment, keep the world quiet and avoid strong light, noise, and other stimulating factors. Use sedatives, oxygen inhalation, cooling and rehydration to maintain water, electrolyte and acid-base balance, and the body temperature drops to about 37 degrees. Iodine. It can reduce the level of thyroxine in blood. Oral compound potassium iodide 3 to 5 more or 10% sodium iodide 5 to 10 more plus 10% GS 500 mg can be given intravenously. And renergic blockers. Reserpine 1 to 2% intramuscular injection or guanidine 5 to 10 mg oral administration or propendol 5% or 10% 100 more meters intravenous drip. Glucocorticoid, it can antagonize the effect of thyroxine. Hydrocortisone, day intravenous drip 200 to 14 mg. For symptomatic treatment, those with heart failure shall be given digital preparation. After the above treatment, patients generally get better in 2 to 4 days, and the mortality rate of patients with serious condition can be as high as 20%. Therefore, it is very important to prevent the occurrence of hypothyroidism crisis. Those who have not effectively controlled hypothyroidism symptoms should not rush to surgery. Let's summarize the surgical treatment of hypothyroidism. Surgical treatment of hypothyroidism has high effective rate, low recurrence rate, and no long-term side effects of drug treatment or radioactive iodine 131 treatment. Strict control of surgical indications and contraindications adequate and perfect perioperative treatment and careful operation by experienced surgeons can ensure that surgical patients can pass the perioperative period smoothly and reduce the occurrence of serious complications. To sum up, surgical treatment of hypothyroidism, as long as strict screening and management, can be regarded as a fast, economic, and safe method.